disease we cannot treat. They are dying because society is yet to make a decision that their life are worse. So thank you very much for your
Understood the
question
frame.
here.
Just give me a minute. I will just make this a minute.
Thank you so much, ma'am. May I request the chairpersons to please invite our next speaker. CV on the display, please.
Now I request Dr. Niranjan Chavan to come over and deliver his lecture.
Hold like this. We know how to do finish later on.
Yeah. Affiliate, he is a professor at Sion President, MOGS, Joint Treasurer,
Hold this phone here.
and SAFOC Committee Member, Mumbai Organizing Secretary,
Just a second.
AICOG, Treasurer,
Pakdo na,
AICOG,
proper pakdo.
and so many from Mumbai.
To everyone in the city of Pearls, Hyderabad, and this is the third day of the conference. I thank the chairpersons to say good words about me, and my topic today is RRRR in obstetric hemorrhage. I come from Sion Hospital, which is a medical college and a general hospital for last 75 years. And it is based in Dharavi, which is the largest slum area of Asia, and it's placed between the eastern and the western express highway. As an institute practitioner and a private practitioner, the delivery in our institute is about 10 to 12,000 per year, and we still get 50% of these patients transferred from other peripheral hospitals and nearby nursing homes. We have a 50 billion population. We are the largest number of population in the world, but maternal mortality has drastically reduced now, and there is morbidity which is still there. Now there are certain protocols, RRRR, I will go through them one by one. So it's very important to know that you have to be very well prepared when you are dealing with such situations. And I recollect my mother, who was a gynecologist, and my teachers in Sion Hospital telling me that before you go ahead to do conservative management, you need to be mentally prepared for this 3S and 1R. So these are the surgical aspects which we are supposed to know. You should be swift in your surgery, you should be safe in what you do, and you should be sure and do relentlessly. Just continue doing it. So a good surgeon must have an eagle's eye, a lion's heart, and a lady's finger. Obstetric hemorrhage is well known to every one of you, and we know the definition of it. Medical care, appropriate training, and availability of blood bank remains the essentials of managing obstetric hemorrhage. We need to be well equipped. We need to be really prepared for such situations to come. Now, these are the patients which come to my hospital and your hospital, and PIH and anemia are the main cause, and 30 to 40% of our patients are still having, in spite of the best treatment, and they land up with obstetric hysterectomy or medical management of obstetric hemorrhage. Unfortunately, sepsis can also set in, and of course there are patients who undergo abortion and they land up with such complications. So we all know the definition of PPH. Well, anything which is more than 500 ml in normal delivery is defined as PPH, and severe PPH is one where you have blood loss of more than 1000 ml. But this is a medical jargon which has been described by the American College of Obstetricians and Gynecologists. And here you can call PPH as a cumulative blood loss more than or equal to 1000 ml that is associated with signs of symptoms or symptoms reflecting hypovolemia within the first 24 hours of the birthing process. We also know that there is something like secondary PPH, which is beyond 24 hours till 6 weeks. So the patient has low systolic blood pressure, tachycardia, a raised respiratory rate, and these are the signs of hypovolemia. I remember the quantity of blood loss, and that's how the perfusion of blood in the sanitary towel will be seen here, starting from 30 ml to 500 ml, and once it is beyond 500 ml, it needs to be buried. So there are different stages which we need to understand for obstetric hemorrhage, and that will depend upon the blood loss, the blood volume, the pulse rate, the respiratory rate, the blood pressure, and the mental state. And we have the stage 4 where there is confusion. We need to proactively decide and go ahead. We are obviously aware of the risk factors which we come across for the dreaded obstetric hemorrhage, which is a catastrophic in the life of an obstetrician, and these are the maternal, fetal and placental. The risk factors are intrapartum and postpartum, and these are all the issues which can lead to the final catastrophic event which we need to mitigate and reduce them. Intrapartum and postpartum are the indications which we have to keep in our mind. Placental issues need to be addressed appropriately by a predetermined diagnosis. We have to take the ultrasound report with a pinch of salt, but remember, these are all the issues which come with our scenario of obstetric hemorrhage. Let me take back you to the physiology of the uterine contraction, which is a very important component of prevention of obstetric hemorrhage, and it is divided into 2 phases. One is a long conditioning phase, and the second one is a short secondary phase. It will all depend at the microscopic level, including of the proteins involved like connexin, ion channels, and the receptors for uterotonic, and the down regulation of nitric acid that leads to the withdrawal of uterine relaxation, and that causes the problem. This is the worst dreaded things which can come in our life anytime. I have seen my resident doctor standing there for 24 hours when the uterus is contracting, relaxing, partially contracting, and that makes a lot of difference. And uterine atony is responsible for 75 to 90% of PPH, and that is the worst thing because there is a lack of oxygen to the uterus. The hemoglobin is low down, the oxygenation capacity is low down, and that sets in. I would like to tell you that if you remove the uterus out, what we call as exteriorization, that also causes uterine atony, where you are doing a cesarean section and you remove the uterus out and start losing the lower uterine segment. It is not in the intra-abdominal environment, and that is also a very important cause. So I tell my residents, never, you exteriorize it, see if there is any trauma, but put it inside and then suture that cesarean section, lower uterine segment. So these are the 40 mnemonics which you are all aware. We need to strategize, and that plan I will tell you. The first is the tone, lack of tone as I described now. Trauma, any injury to the vaginal birth canal has to be appropriately decided. Just open the legs of the patient, put your fingers, try to assess them, feel for any vaginal laceration, a cervical tear, which you will miss, and that will cause obstetric hemorrhage. Never take it lightly. Always, when you are transferring patient from the labor ward to the PNC ward, just do a gentle PV examination, remove the clots, and that also confirms that yes, your patient doesn't have any trauma. And these are then issues later on to be the worst scenario. Tissue, retained placental tissue. We always use a mop while doing a cesarean section and remove out the retained placental bits and the membranes. Similarly, in the normal delivery, you need to do that. Of course, you have an ultrasound, you can go ahead and in the OT or in the recovery room, that is a very helpful tool. This is something which we need to understand, and a thrombus at a micro level can be very catastrophic, And it starts with a reversible DIC with a hematuria, concentrated urine, and then it affects the kidneys, and then we have DIC. By the time it is irreversible, we need to then hurry up and perform the surgical skills so that we do not have a mother's loss. So these 4 T's we always remember in our mind and always are going to help us with the management. So let's come to the clinical strategies. RRRR. So first is the structural preparation elements. You need to have a blood collection card, a transfusion protocol ready, and that is the readiness. Investment of time is very important, and no undue delay should be there. Second is recognition and prevention. You recognize these 4 T's. It's very important so that you can prevent the outward situation which can come. And the response, which has to be a multidisciplinary effort, and that will depend upon the existing resources, a specific unit being there. In Sion Hospital, we are 6 units, 3 professors, 5 associate professors, and 12 lecturers, and there are 20 residents being coming to our institute from all over India, and we are prepared, and the response has to be there. I have not got a single maternal mortality in my unit from March 2023 till December 31st. And I'm very proud of my response team and the residents, and that is what we need to teach, not only about reduction in the incidence of cesarean section, but to reduce the obstetric hemorrhage. And then we have reporting and systems. We have quasi-judicial body. We go to F-South. We have every monthly meetings there. Auditing is very important, and the systems are in place. And that's what we are progressing. I have 2 minutes, please. Thank you. So this is the flow chart we all are aware to manage how the T's, and then we have carbitocin, the new kid on the block, with oxytocin and methergine to be there to suture the trauma, to see that the retained placental bits are removed, and the thrombin is reduced by giving her fresh frozen plasmas, HDPs, etc. And then further transfusion protocols have to be set in. This is the obstetric team on one side. We have the multidisciplinary or the anesthetic team on the other side. We come together, and that's how we can go on treating them conservatively, either by giving a uterine massage or intrauterine balloon tamponade, and keep your obstetric OT ready for an emergency hysterectomy, which is to be avoided as far as possible. But before that, if you have a radiological department, an interventionist on call, you can surely embolize them with this. So standardization of current practices is very important, and management of comprehensive protocol, innovation in treatment. I am doing a FIGO trial. The emotive trial is already in place. The role of tranexamic acid in our day-to-day life is a game changer, and it is surely going to reduce the mortality and return. My student will be getting this thesis topic, and for the next 2 years, we are going to dwell on this trial, which has been the LDI project by FIGO in our hospital. And I thank the President, Dr. Rishikesh Pai, Shanta Kumari, and the incoming President, Jaideep Tam, for giving this trial to Sion Hospital. Dissemination is very important of the practice guidelines, auditing and feedback. Human and physical resources are aplenty in our country. Use them to battle out the hemorrhage-related morbidity and mortality. Just half a minute, please. Competence is teaming, training and simulation. The National Medical Council has made it mandatory for all the medical colleges to have henceforth a simulation lab. So that is going to be a change in our scenario in our country. Biases have to be removed. There are 2 types of biases. One is the confirmation bias, and the second is the tolerance of ambiguity. Never have ambiguity. Have a clear decision-making power. Have a proper look in an affirmative approach, and that biases can be removed, and we need to work on this. There is something like choice architecture and forcing functions, and you have a hemorrhage code. We have a hemorrhage code in our hospital, do that. And of course, there are various conservative methods which can come across. Now, when you are dealing with such situation, the patient is informed, the relatives are informed, and if an unfortunately an obstetric hemorrhage occurs and you need to do a hysterectomy, the loss of that organ is a very important situation for the mother. That grief which strikes should not be a sudden bolt coming to the family.
Sorry to interrupt, requesting you
Thank
to
you.
please conclude.
With this, I would like to conclude that you need to secure necessary resources, build team training, have simulation, remove biases, facilitate the patient and family supporting system, performance improvement and risk mitigation for obstetric hemorrhage, and to establish standardized approach. These are my references. Thank you so much, and I invite you to come to AICOG 2025 Mumbai. Mumbai welcomes you. I want to play this video. 1 minute please. Thank you. Welcome to Mumbai.
है दिल है मुश्किल जीना यहाँ जरा हट के जरा बच के ये है बॉम्बे मेरी जान